The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of Inside JACC. And today I'm talking to Dr. Chris O'Connor, who's probably well known to this audience. And Chris is the director of the Duke Heart Center and professor of medicine at Duke. And he's the senior author of a very interesting paper that deals with the results of heart failure randomized clinical trials employing beta blockers as they relate to differences between patients in the United States and the rest of the world. And Chris and his associates looked at four major beta blocker randomized trials, the BEST trial, the CBIS-2 trial, Copernicus and Merit heart failure, and they observed that there was a considerable difference between the response of patients in these trials in the United States and the rest of the world. For instance, the composite difference being about a 23% benefit, but only 8% in the United States, about 36% in the rest of the world. So, Chris, I guess the first question we might ask is, why is it that there's such a large percentage of participants from the rest of the world in these very important randomized trials?
Well, Dr. DeMaria, thank you for bringing this to the attention of the readership, because I think this is very important. We now have to do clinical trials globally in order to achieve these trial results and conduct them faster. Patient recruitment has to be large, it has to be diverse, and so clinical trials are done internationally these days.
Is a large factor responsible for that, the difficulty in conducting randomized trials in the United States?
There clearly has been greater difficulty in the United States over the past 2 decades because of regulatory issues and the complexity of doing site-based research in healthcare systems that require enormous emphasis on efficiencies. And frankly, the event rates are things that drive clinical trials can be greater in the rest of the world.
So I guess the question, Chris, is what's the effect upon how we interpret these results when we have a large percentage of enrollment from outside the United States and the patients may differ in terms of comorbidities and access to other medications, et cetera?
Well, that's exactly right. I think the key thing when we conduct these trials is, first of all, to make sure we capture the differences, the baseline characteristics, the characteristics of the healthcare systems, the differences in standard of care, and the differences in event rates. But once we do that, I think what I'm advocating from this paper is that we should absolutely think about stratifying and looking at regional differences up front in a prospective manner.
Very interesting, and I think a very important point. Your paper clearly demonstrates that the data that we get from these trials differs a bit in patients in the States from the rest of the world, and we have to take that into account when we apply these results to our individual patients. Thanks very much for being with us. For Inside JACC, I'm Tony DeMaria.